Hi, everyone. My name is Catherine Sisler, and I would like to welcome you to today's CDC Partner Update call on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19 and our latest resources and guidance. Today's call will focus on the recently released operational strategy for K-12 schools. First, we will hear from one of our medical officers on the CDC COVID-19 emergency response, who will describe where we are with the response and give us insight into recent scientific findings. Then we will hear from a member of our Community Interventions and Critical Populations Task Force, part of the CDC COVID-19 emergency response, who will share information on the recommendations provided in the new operational strategy for K-12 schools. Afterwards, our speakers will answer questions we received over the last week via email. If you experience technical difficulties or otherwise would like to review today's call, you can find the recording on cdc.gov and YouTube in 8 to 10 days. All past partner calls can be found there, so please take time to review and share prior recordings. If this is your first webinar with us, these calls generally occur every Monday at 3 p.m. Eastern. Today is an exception with a 3:30 start. Please see the link on the slide to subscribe and receive future call invitations. And please note, this call is not intended for media, although we welcome the media who may be here today. Should media have questions, we invite you to reach out to media@cdc.gov. Also, we will have two short polls, one now and another at the end of the presentation, to get feedback about the effectiveness of these calls. Please answer the poll now as we get started, and then again before we start the Q&A section. These calls are designed to share the latest science, guidance, and resources from CDC's website. There are over 2,000 documents providing information and guidance for individuals, businesses, and the public on cdc.gov. In addition to the resources we'll discuss today, we'd like to highlight a few recent web additions. First, we'll highlight CDC's new global variant case map. This map is updated weekly and shows which countries have reported variants of SARS-CoV-2. Second, starting February 12th, CDC's COVID View has been replaced with the COVID Data Tracker Weekly Review. This new webpage and newsletter will highlight key data from CDC's COVID Data Tracker, narrative interpretations of the data, and visualizations from the week. The new weekly review will also summarize important trends in the pandemic and bring together CDC data and reporting in a centralized location. It represents the extensive data that CDC uses to track the pandemic on a daily basis and will incorporate additional data sources in the future. You can sign up using the link in the chat to have the COVID Data Tracker Weekly Review delivered to your inbox every week. Next, the National Forum on the COVID-19 Vaccine, organized by CDC, will be taking place starting today through Wednesday. Offering 3 days of information geared towards practitioners responsible for ensuring vaccination strategies are implemented, the forum will feature national, state, tribal, community, and private sector experts. Registration information will be linked in the chat, where you will also be able to find session recordings and other materials. Finally, we would like to note that updated data for risk of COVID-19 infection, hospitalization, and death by race and ethnicity is now available on the CDC website. I'm pleased today to be joined by two CDC experts on the COVID-19 response. Dr. Cliff McDonald is a medical officer serving in support of the Chief Medical Officer on the CDC COVID-19 emergency response. Dr. Greta Massetti is the co-lead of the Community Interventions and Critical Populations Task Force on the COVID-19 response. Now, let me turn it over to Dr. McDonald for some updates.
Thank you, Catherine, and welcome to everyone joining us today. My name is Dr. Cliff McDonald, and as mentioned, I am a medical officer serving in support of the Chief Medical Officer for the response. Today, I'd like to provide a brief update on the response and review some of the latest scientific developments. First, a situational update on cases and deaths. You can see from the slide that cases and deaths are decreasing nationally, and this is good news. The weekly average of cases has decreased by 29.2% over the previous week, and the weekly average deaths has decreased by 38.8%. 8% over the previous week. These statistics provide us with valuable information when these percentages are decreasing. This tells us that mitigation efforts are working. When case counts increase, this tells us that we need to step up mitigation efforts to slow the spread of COVID-19. It is also important to note that there is continued evidence that some racial and ethnic minority groups, particularly Black or African American, Hispanic or Latino, and American Indian or Alaska Native people are disproportionately affected by COVID-19. Inequities in the social determinants of health, such as poverty, access to culturally appropriate information, working conditions, and quality healthcare influence a wide range of health and quality of life income outcomes and risks. We encourage you to visit CDC's data tracker and the new weekly review for the latest stats and key indicators for the pandemic. New this week, I want to share some of what we've learned from 3 reports released in CDC's Morbidity and Mortality Weekly Report, or MMWR. In the interest of time, I will only briefly touch on the high points of these reports, and I encourage you to visit cdc.gov to read the full reports. First, we want to highlight an MMWR on maximizing fit for masks. Masks substantially reduce exhaled respiratory droplets and aerosols from infected wearers and reduce exposure to uninfected wearers to these particles. Cloth masks and medical procedure masks fit more loosely than do respirators, such as N95 filtering face piece respirators. The effectiveness of cloth and medical procedure masks can be improved by ensuring that they are well fitted to the contours of the face to prevent leakage of air around the mask's edges. CDC conducted experiments to assess 2 ways of improving the fit of medical procedure masks: fitting a cloth mask over a medical procedure mask and knotting the ear loops of a medical procedure mask, and then tucking in and flattening the extra material close to the face. Each modification substantially improved source control and reduced wearer exposure. These laboratory-based experiments highlight the importance of good fit to optimize mask performance. Second, we would like to share an MMWR on trends in the use of telehealth and among health centers during the COVID-19 pandemic. During June 26 through November 6, 2020, 30.2% of weekly health center visits occurred via telehealth. Telehealth visits declined as the number of new COVID-19 cases decreased, but plateaued as the number of cases increased. The overall average percentage of weekly telehealth visits differed significantly among some regions. Health centers in the South census regions and rural areas reported the lowest average percentage of weekly telehealth visits compared with health centers in other census regions and urban areas. Although in-person visits are needed to provide timely routine care and for urgent and emergency situations, maintaining telehealth capacity is critical during the COVID-19 pandemic. Telehealth visits can facilitate patient triage, which can reduce the effect of patient surge on facilities, address limitations to healthcare access, conserve personal protective equipment, and reduce disease transmission. Third, we'd like to share an MMWR on the first month of COVID-19 vaccine safety monitoring. Since the Pfizer, BioNTech, and Moderna vaccines were authorized in December 2020, safety monitoring for these vaccines has been the most intense and comprehensive in U.S. vaccine history. In this report, investigators describe data from 2 vaccine safety monitoring systems during the first month of the COVID-19 vaccination program: the Vaccine Adverse Events Reporting System, or VAERS, and vSafe, a new phone app-based monitoring system developed specifically for the COVID-19 vaccination program. During December 14th, 2020 to January 13th, 2021, almost 14 million doses were administered. During this time, 6,994 reports of adverse events were submitted to the VAERS system following vaccination. and VSafe enrolled 1,602,065 vaccine recipients who completed at least one survey. Most, or 90.8% of VAERS reports were non-serious. The most common symptoms reported in VAERS were headache, fatigue, and dizziness. With that, it is now my pleasure to hand you over to Dr. Greta Massetti.
Thank you, Dr. McDonald. As we mentioned previously, I'm Dr. Greta Massetti. I'm the lead of CDC's COVID-19 Emergency Response, Community Interventions, and Critical Populations Task Force. Schools are an important part of the infrastructure of communities. They provide safe, supporting learning environments for students and employed teachers and other staff. CDC educators and communities share the goals of getting schools open as safely and as soon as possible, as well as making sure that it's safe for students, teachers, staff, and their families. As CDC has approached developing recommendations, we have been guided by several principles. One is the awareness of the disease in the community. The level of disease in the community informs risk of disease in the school setting. 2 is the decision on when and how to begin in-person learning must be based on a thorough review of what the science tells us works. And finally, we must learn from the experiences, challenges, and perspectives of teachers, school staff, parents, and students as we consider the right path forward. On February 12th, CDC released 2 key resources, a science brief on SARS-CoV-2 transmission in schools and an operational strategy for K12 schools through phased mitigation. The science brief reflects a thorough review of the science and data to date about COVID-19 among children and adolescents, as well as the evidence on SARS-CoV-2 transmission in schools. In January, CDC published an MMWR on data from 2,871,000 laboratory-confirmed cases of COVID-19 among children, adolescents, and young adults ages 0 to 24. Among children, adolescents, and young adults, weekly incidence or cases per 100,000 persons increased with age and was highest during the week of December 6th among all age groups. Reported incidence and positive test results among children aged 0 to 10 years were consistently lower than those in older age groups. The findings from this study were similar to results from other studies about COVID-19 among children and adolescents. There are several conclusions from this body of evidence. Although children can be infected with SARS-CoV-2, can get sick from COVID-19, and can spread the virus to others, less than 10% of COVID-19 cases in the United States have been among school-aged children and adolescents aged 5 to 17 years. Compared with adults, children and adolescents who have COVID-19 are more commonly asymptomatic, meaning they never develop symptoms, or have mild non-specific symptoms. Similar to adults with SARS-CoV-2 infections, children can spread SARS-CoV-2 to others when they don't have symptoms or have mild nonspecific symptoms, and thus might not know that they are infected and infectious. Younger children have lower incidence and test positivity than adolescents, suggesting that the risk for transmission is lower for elementary schools compared to middle and high schools. Overall, children are less likely to develop severe illness or die from COVID-19 than adults. The science brief also summarizes many studies of SARS-CoV-2 transmission, both internationally and in the United States. The studies show that levels of community transmission are associated with increased risk of transmission in schools. As the level of disease increases in communities, so does the likelihood that there will be cases and spread in schools. Another key finding is that staff-to-staff or teacher-to-teacher transmission is more common than student-to-teacher, teacher-to-student, and student-to-student. Thus, adults are the primary source of exposure to SARS-CoV-2 for teachers and staff. The science also suggests there is more spread in middle schools and high schools than elementary schools. We also looked at what the studies say about which activities pose the greatest risk of school-related transmission. I'm going to share the bottom line up front. Essentially, the highest risk activities are those where people cannot keep distance or wear a face mask consistently and correctly. We reviewed dozens of studies that looked at transmission in schools from other countries and from the US. For example, An MMWR of pediatric COVID-19 from Mississippi found that children with COVID-19 were more likely to have had close contact with a person with known COVID-19, have attended gatherings with persons outside of their household, including social functions, or have had visitors into their home. In-person school attendance was not associated with increased odds of COVID-19 in children in this study. Another study of 11 North Carolina school districts providing in-person instruction in the fall found that among more than 90,000 students and staff, there were 773 cases of SARS-CoV-2 infection acquired in the community and 32 acquired within schools. No instances of student to staff transmission of SARS-CoV-2 were reported within schools. The study found limited within school secondary transmission of SARS-CoV-2. Another study published in MMWR from 17 schools in Wisconsin found that incidence among students and staff members was lower than in the county overall. Among 191 cases identified in students and staff members, only 7 cases, or 3.7%, all among students were linked to in-school spread. These findings suggest that with proper mitigation strategies, K12 schools can open for in-person learning with minimal in-school transmission of SARS-CoV-2. There was also an MMWR in January from an investigation of a COVID-19 outbreak associated with a high school wrestling tournament from December 2020. The tournament included 10 schools and 130 student athletes, coaches, and referees. Among the 130 tournament participants, 38 had SARS-CoV-2 infection diagnosed, but less than half the participants were tested. At least 446 household, school, and community contacts were identified. Secondary transmission occurred among contacts, and at least 1 death was reported in a contact. An estimated 1,700 in-person school days were lost as a consequence of isolation and quarantine of patients and contacts during this outbreak. To maximize in-person education, high-contact athletic activities should be postponed during periods with high levels of SARS-CoV-2 community transmission. The main conclusion from the review of studies is that transmission in schools can be limited by using mitigation strategies, especially masks and physical distancing. Spread within schools is generally due to lack of mask use and lax mitigation. Sports and other activities where masking and distancing are not possible increase risk of spread. And when levels of community transmission are high, there is higher risk of in-school transmission. CDC recently released its operational strategy for K12 schools. The operational strategy reflects current evidence summarized in CDC's science brief. This strategy provides a pathway to open schools for in-person instruction and help them remain open through consistent use of mitigation. It is critical for schools to open as safely and as soon as possible and remain open to achieve the benefits of in-person learning and key support services. The strategy contains a package of tools to support safe in-person instruction at all levels of community transmission for all schools. The strategy provides 3 essential elements. The first is layered mitigation, or using multiple strategies at once to reduce transmission. The second essential element is indicators of community transmission, which is information about the level of disease in the community. And the third essential element is phased mitigation, or recommendations about mitigation strategies based on levels of community transmission. There are also 2 additional layers of prevention, testing, and vaccination. The operational strategy does not mandate that schools reopen, nor does it mandate that schools that are already open should close. Rather, we are providing science-based recommendations to help schools create an in-person environment that is safe for students, teachers, and staff. The recommendations in the strategy reflect several core concepts. The first is that schools should be the last setting to close and the first to reopen safely in communities. The second is that at any level of community transmission, all schools have options to provide in-person instruction, either full or hybrid, through strict adherence to mitigation. Lower incidence of COVID-19 among younger children compared to teenagers suggests that elementary schools are likely to have less in-school transmission than middle schools or high schools. Students, teachers, and staff who are at increased risk of severe illness or who live with people at increased risk should be given the option of virtual instruction, regardless of the mode of learning offered. Cohorting or podding is encouraged to facilitate testing and contact tracing and minimize transmission across pods. and in-person instruction should be prioritized over extracurricular activities, including sports and school events, to minimize risk of transmission in schools and protect in-person learning. The strategy also addresses health equity considerations and provides specific recommendations and guidance on integrating health equity and planning for in-person learning. The absence of in-person education may disadvantage children from low-resourced communities, including those with large representation of racial and ethnic minority groups, English learners, and students with disabilities. In-person instruction in K-12 schools must consider efforts to provide fair access to healthy educational environments for students and staff. Health equity considerations built into all aspects of the K-12 strategy, including mitigation, testing, and vaccination. Now I'm going to tell you a little bit about the recommendations in those three essential elements of safe in-person instruction. Regardless of the level of community transmission, all schools should use and layer mitigation strategies. 5 key mitigation strategies are essential to safe delivery of in-person instruction and help to mitigate COVID-19 transmission in school. The first is requiring universal and correct use of masks. They should be worn at all times by all persons in school facilities with certain exceptions. The second is physical distancing to the greatest extent possible. We encourage schools to establish school policies and implement structural interventions to promote physical distance of at least 6 feet between people. Hand washing and respiratory etiquette. Cleaning and maintaining healthy facilities includes routine cleaning, high-touch services, and making changes to physical spaces to maintain a healthy environment, and facilities including ventilation, food service, physical barriers, and guides. Finally, contact tracing in combination with isolation and quarantine. Schools should collaborate with their health departments to provide information to facilitate contact tracing. All strategies provide some level of protection, and layered strategies implemented concurrently provide the greatest level of protection. Schools doing in-person instruction should prioritize 2 mitigation strategies. Universal and correct use of masks should be required at all levels of community transmission, and physical distancing at least 6 feet should be maximized to the greatest extent possible. The second essential element is indicators of community transmission. This provides school leaders information about the amount of disease in the community. The more disease, the greater the likelihood that virus will be introduced in the school environment. CDC recommends the use of 2 measures of community burden to determine the level of risk of transmission. Total number of new cases per 100,000 persons in the past 7 days, and percentage of nucleic acid amplification test results that are positive during the last 7 days. Combined, these indicators can help schools understand what level of transmission is in their community: low, blue; moderate, yellow; substantial, orange; and high, red. The 2 measures of community burden should be used to assess the incidence and spread of SARS-CoV-2 in the surrounding community, such as the county. The transmission level will change over time. We recommend reassessing weekly for situational awareness and to help schools plan. The third essential element is phased mitigation by level of community transmission. This table presents an operational plan for schools that emphasizes mitigation at all levels. Schools should require universal and correct use of masks at all levels of community transmission. And at low and moderate levels, we recommend full in-person instruction with physical distancing to the greatest extent possible. At substantial and high levels, we recommend considering hybrid mode or other instructional approaches to allow for a full 6 feet of physical distancing. There are also recommendations for sports, extracurricular activities, and school events. We recommend stricter mitigation in these activities so that instructional time can be protected. School leaders are encouraged to make decisions about learning mode based on levels of community transmission, but also taking their own school's experiences into account. Decisions should be guided by information on school-specific factors such as mitigation strategies, the number of cases among students, teachers, and staff, and school experience with school reopening. Schools that are already open may decide to maintain their current status, either full in-person or hybrid, regardless of the level of community transmission. Such situation, a decision to remain open should involve considerations for further strengthening mitigation strategies and continuing to monitor case incidents and test positivity to reassess decisions. Despite careful planning and consistent implementation of mitigation, some situations may occur that lead school officials to decide to temporarily close schools to in-person instruction. Such situations may include classrooms or schools experiencing an active outbreak, and schools in areas experiencing rapid or persistent rises in case incidents or severe burden on healthcare capacity. Testing is one layer of additional prevention in school. When schools implement testing combined with key mitigation, they can detect new cases to prevent outbreaks and reduce the risk of further transmission. At all levels of community transmission, all schools should offer referrals to diagnostic testing to any student, teacher, or staff member who is exhibiting symptoms of COVID-19 at school. Some schools may also elect to use screening testing as a strategy to identify cases and prevent secondary transmission. Screening testing can be used as an additional layer of mitigation to complement mitigation strategies in schools. And screening testing is intended to identify infected individuals without symptoms or prior to the development of symptoms who may be contagious so that measures can be taken to prevent further transmission. When determining which individuals should be selected for screening testing, schools and public health officials may consider prioritizing teachers and staff over students, given the higher risk of severe disease outcomes among adults. In selecting among students, schools and public health officials may prioritize high school students, then middle school students, then elementary school students. Public health officials and school administrators may consider placing a higher priority for access to testing in schools that serve populations experiencing a disproportionate burden of COVID-19 cases or severe disease. These may include schools and communities with moderate or large proportions of racial and ethnic minority groups that have experienced disproportionately high rates of COVID-19 cases relative to population size, and schools in geographic areas with limited access to testing due to distance or lack of availability of testing. Before implementing testing in their schools, K12 administrators should coordinate with public health officials to develop a testing plan. Testing requires a dedicated infrastructure and resources to support school-based testing and use of tests that are authorized by FDA for the specific intended use, and a mechanism in place for prescription test orders by a licensed healthcare provider. CLIA certificate of waiver requirements to perform school-based testing are needed, a mechanism to report all testing results, both positive and negative. And when considering which tests to use for screening testing, tests that can be reliably supplied and that can provide results within 24 hours should be chosen. Additional needs include a way to obtain parental consent for minor students and assent or consent for the students themselves, physical space to conduct testing safely and privately, the ability to maintain confidentiality of results and protect student privacy, and plans for confirmatory testing when needed through the health departments for symptomatic persons who receive a negative test result and asymptomatic persons who receive a positive test result. The Advisory Committee on Immunization Practices and CDC have endorsed the guiding principles of efficiency for the COVID-19 vaccination program. Efficient, expeditious, and equitable distribution and administration of approved vaccine is critical. Within national guidelines, state and local jurisdictions should have flexibility to administer vaccine based on local epidemiology, resources, and demand. ACIP recommends that frontline essential workers, including those who work in the education sector, like teachers and school staff, be prioritized for vaccine allocation in Phase 1B, following healthcare personnel and residents of long-term care facilities in Phase 1A. Within each jurisdiction, it is not necessary to completely or fully administer vaccine to all eligible persons in one phase before expanding to the next phase. Decisions regarding transition from one phase to the next should be made at the jurisdictional level. Demand for vaccine and implementation challenges will vary from one jurisdiction to the next, so when and how jurisdictions move to and through phases will vary. Teachers and school staff hold jobs critical to the continued functioning of society and are at potential occupational risk of exposure to SARS-CoV-2. Jurisdictional officials should consider giving high priority to teachers in early phases of vaccine distribution. Vaccinating teachers and school staff can be considered one layer of mitigation and protection for staff and students. Minimizing barriers to accessing vaccination for teachers and other frontline essential workers, such as vaccine clinics at or close to the place of work, are optimal. Access to vaccination should nevertheless not be considered a condition for reopening schools for in-person instruction. Even after teachers and staff are vaccinated, schools need to continue mitigation measures for the foreseeable future, including requiring masks in schools and physical distancing. Just a reminder that CDC has numerous school tools available to assist you with your work for our communities. You can always visit CDC COVID schools and childcare for the latest information from CDC. Success in preventing COVID-19 in schools begins with and is connected to preventing transmission in communities. When communities implement and strictly adhere to mitigation strategies, the level of community transmission is slowed. This will, in turn, enable schools that are open for in-person learning to stay open and help schools that have not yet reopened to return to in-person instruction. And thank you. That concludes my overview.
Thank you to Dr. Massetti for sharing those updates. We will now move on to the question and answer portion of our call. But before we get started, please take a moment and answer a couple of questions through the poll on your screen. We've received many great questions in advance for the Q&A portion of our call, and we will get to as many of those as we can in the next half hour or so. My first question here is for Dr. McDonald, and it's related to people who have received their COVID-19 vaccination. Will those who have been vaccinated still need to quarantine if they are exposed to a COVID-19 positive patient?
Well, this is a great question, as CDC just updated its clinical considerations for mRNA vaccines on February 10th, which included updated quarantine guidance for vaccinated persons. At this time, vaccinated persons should continue to follow current guidance to protect themselves and others, including wearing a mask, staying at least 6 feet away from others, avoiding crowds, avoiding poorly ventilated spaces, covering coughs and sneezes, washing hands often, following CDC travel guidance, and following any applicable workplace or school guidance, including guidance related to personal protective equipment use or SARS-CoV-2 testing. However, vaccinated persons with an exposure to someone with suspected or confirmed COVID-19 are not required to quarantine if they meet all of the following criteria. They are fully vaccinated. That means 2 or more weeks following receipt of the second dose in a 2-dose series, or 2 or more weeks following receipt of 1 dose of a single-dose vaccine. Second, they are within 3 months following receipt of the last dose of the series. And third, they have remained asymptomatic since the current COVID-19 exposure. This recommendation to waive quarantine for people with vaccine-derived immunity aligns with quarantine recommendations for those with natural immunity, which eases implementation.
Thank you, Dr. McDonald. Next question is for you again. Why aren't people tested for COVID-19 before they receive their vaccination?
Well, the data from clinical trials indicate that mRNA COVID-19 vaccines can safely be given to persons with evidence of a prior SARS-CoV-2 infection. Vaccination should be offered to persons regardless of history of prior symptomatic or asymptomatic SARS-CoV-2 infection. Viral testing to assess for acute SARS-CoV-2 infection or serologic testing to assess for prior infection for the purposes of vaccine decision-making is not recommended at this time. Persons residing in congregate settings, such as healthcare and non-healthcare congregate settings, who have had an exposure and are awaiting results of SARS-CoV-2 testing may be vaccinated if the person does not have symptoms consistent with COVID-19. In situations where facility-wide testing is being conducted to identify SARS-CoV-2 infections, facilities should attempt to complete facility-wide testing within a period that allows for test results to be received prior to vaccination in order to isolate those patients with SARS-CoV-2 infection, that is, active infection. However, it is not necessary to wait for test results if this would create delays in vaccination. In such situations, persons without symptoms consistent with COVID-19 may be vaccinated. Although not contraindicated, vaccination may be deferred pending outcome of testing in persons with symptoms consistent with COVID-19. Viral testing for acute SARS-CoV-2 infection solely for the purposes of vaccine decision-making is not recommended.
Thank you, Dr. McDonald. Third question for you. How do pharmacies get reimbursed for vaccinating those who are uninsured?
The federal government is providing vaccine free of charge to all people living in the United States. Vaccination providers can be reimbursed for vaccine administration fees by the patient's public or private insurance company, or for uninsured patients by the Health Resources and Services Administration Provider Relief Fund. No one can be denied a vaccine if they are unable to pay a vaccine administration fee.
Thank you, Dr. McDonald. It's helpful to know. Dr. Massetti, I have a few questions for you. We'll start with, what if schools can't operate with 6 feet of distance between students, teachers, and staff?
So CDC recommends that schools should do their best to keep people at least 6 feet apart to the greatest extent possible. At low and moderate levels of community transmission, this may mean that desks may not be able to be between 6 feet apart, because we are recommending full in-person instruction. At substantial and high levels of community transmission, we recommend hybrid or reduced attendance to allow for that full 6 feet. To ensure physical distance, schools should establish policies and implement steps to keep people apart, such as sneeze guards and partitions. We also recommend establishing small groups of students who stay together day to day without direct contact with other students to minimize exposure across the school setting. This is often cohorting or potting.
Thank you, Dr. Massetti. What is substantially different between blue, yellow, orange, and red? What would a school specifically have to change as community transmission changed?
So when making decisions on when to open schools for in-person learning, it is important to understand the level of transmission within the surrounding community. As levels of community transmission increase, our recommendations adapt based on that level. We use color indicators to aid school administrators and states in their decision-making process, like the beginning, continuing, or pausing in-person learning. At high or red levels, middle and high schools may shift to virtual instruction unless they are already open with universal and correct use of masks and physical distancing, and if they have success in maintaining minimal or no secondary transmission in schools. Some schools or parts of a school, such as a class or grade level, may close temporarily if they are experiencing an active outbreak. Some schools in areas experiencing rapid or persistent rises in case incidents or severe burden on healthcare capacity may also decide to close until levels of community transmission stabilize. Temporary closure decisions should be based on careful consideration of a variety of factors. If after applying the core indicators, a school whose risk of transmission is yellow, orange, or red, it does not mean that the school cannot be open for in-person learning. Introduction and subsequent transmission of COVID-19 is higher, and the school could consider alternative learning models. Similarly, if a school's indicators are all blue, it does not mean that the school should relax adherence to mitigation measures. Regardless of the level of risk as determined by the color indicators, it is critical that schools use multiple mitigation strategies, including consistent and correct use of masks and physical distancing. Officials should frequently monitor these indicators and adjust accordingly. School administrators can apply the same color indicators to adjust the way sports, extracurricular activities, and school events are delivered. At moderate or yellow levels, these activities should only be implemented if masking and physical distancing are possible. At substantial levels, they should only be implemented outdoors with masking and distancing. And at high or red levels, these activities should be virtual or postponed.
Thank you, Dr. Massetti. A follow-up question. Is there any level of community transmission where CDC would say schools in that community should close?
CDC's K12 operational strategy recommends that K12 schools can be open even at the highest level of community transmission if strict mitigation measures are consistently in place. We recommend hybrid learning at the highest levels of community transmission. Hybrid learning reduces the number of students in the classroom, which improves schools' ability to physically distance.
Thank you, Dr. Massetti. Dr. McDonald, we have a question for you. Is there an update on the approval process for the Johnson & Johnson vaccine and the AstraZeneca vaccine?
Well, as COVID-19 vaccines are authorized and then recommended for use in the United States, it will be important to understand what is known about each vaccine. CDC will provide information on who is and who is not recommended to receive each vaccine and what to expect after vaccination, as well as ingredient safety and effectiveness. Currently, 2 vaccines are authorized and recommended to prevent COVID-19. The Pfizer-BioNTech COVID-19 vaccine and Moderna's COVID-19 vaccine, both are mRNA vaccines. There are large-scale phase 3 clinical trials in progress or recently completed for 3 additional COVID-19 vaccines in the United States. First, the AstraZeneca's COVID-19 vaccine. A large trial is ongoing in the United States at this time. Second, the Johnson & Johnson or Janssen COVID-19 vaccine. This company has recently announced top-line results of their pivotal phase 3 trial, and according to that press release, have applied for an FDA emergency use authorization. And Novavax COVID-19 vaccine has a large trial ongoing in the United States at this time.
Thank you for that update, Dr. McDonald. Another general vaccine question. Can an employer require an employee to receive the COVID-19 vaccine?
Well, the federal government does not mandate vaccination for individuals. For some healthcare workers or essential employees, a state or local government or employer, for example, may require or mandate that workers be vaccinated. Whether an employer may require or mandate vaccination is a matter of state or other applicable law. If an employer requires employees to provide proof that they have received a COVID-19 vaccination from a pharmacy or their own healthcare provider, the employer cannot mandate that the employee provide any other medical information as part of that proof.
Thank you, Dr. McDonald. That's helpful to know. Dr. Massetti, we have a few more K-12 operational questions for you. So first, what should happen in a school with older ventilation systems? Should they be closed until fully upgraded, or should they do something else?
So associating building age with the ability to implement protective ventilation strategies usually is an overly broad assumption. Many older buildings with operable windows and leaky construction infrastructure could easily have better dilution ventilation capacity than their newer energy efficient counterparts. The CDC guidance and operational strategy prioritizes 2 mitigation strategies to support safe school reopening: universal and correct use of masks and physical distancing to the greatest extent possible. These 2 mitigation strategies are essential to reducing SARS-CoV-2 transmission and are independent of facility age. Other mitigation strategies, including cleaning and maintaining healthy environments, hand washing, contact tracing, and enhancing building ventilation, provide added layers of protection aimed to prevent transmission. The appropriate selection of ventilation strategies will be school-specific and not necessarily dependent upon the age of the school buildings or its ventilation systems. You can refer to CDC's Ventilation and Buildings webpage for a list of considerations to improve building ventilation as part of a layered strategy to reduce exposures to SARS-CoV-2. A list of frequently asked questions to aid selection and implementation of the considerations is also included. The ventilation intervention considerations identified at the CDC's Ventilation and Buildings webpage come with a range of initial costs and operating costs. Examples of per room acquisition cost estimates include at no cost, things like opening windows, inspecting and maintaining local exhaust ventilation, disabling demand-controlled ventilation controls, or repositioning outdoor air dampers. At less than $100, schools can use fans to increase effectiveness of open windows or reposition supply and exhaust diffusers to create directional airflow. Between $500 and $1,000 includes adding portable HEPA fan or filter systems. Larger rooms may require multiple units or larger, more expensive units. And around $1,500, schools can add upper room ultraviolet germicidal irradiation. There's a common misperception that open windows and window fan considerations are not applicable for cold weather. That is not entirely correct. Use of a window fan in exhaust mode can still be augmented by opening multiple windows just an inch or so along the room entry door. This setup will allow a substantial inflow of dilution air, but will do so in multiple small drafts. The remaining room air temperature can be increased by a couple of degrees to offset by the cold air drafts. There's also a study that we will be sharing where older schools had better ventilation, meaning basically draftier schools are better than new schools that are hermetically sealed.
Thank you, Dr. Massetti. That's helpful information and helpful resources. We have a couple more questions relating to the school strategy. So what if our school district does not currently have a testing plan or the capacity for the kinds of testing recommended in the new operational strategy?
So the first answer to that question is that not all schools are recommended to use screening testing. So the operational strategy suggests that some schools may consider using expanded screening testing as one layer of mitigation, but we also provide pathways for reopening for in-person instruction, even for schools that decide not to use screening testing. For those schools that do decide to use screening testing, before implementing testing in their schools, K12 administrators should coordinate with public health officials to ensure there is support for this approach from students, parents, teachers, and staff to develop a testing plan that has key elements in place. These include a dedicated infrastructure and resources, a mechanism for reporting test results, obtaining consent from students and the parents of minors, among other considerations. Taking into consideration the potential for limited availability of supplies for screening testing or feasibility of implementing screening testing, schools may consider a prioritization strategy. When determining which individual should be selected for screening testing, schools and public health officials may consider prioritizing teachers and staff over students, given the increased risk of severe illness among certain adults. In selecting among students, schools and public health officials may prioritize high school students, then middle school students, and then elementary school students, reflecting higher infection rates among adolescents compared to younger children. Health equity is another consideration when it comes to prioritization for testing. Public health officials and school administrators may consider placing a higher priority for access to testing in schools that serve populations experiencing a disproportionate burden of COVID-19 cases or severe disease. These include schools and communities that have experienced disproportionately high rates of COVID-19 relative to population size, and schools in geographic areas with limited access to testing. Not every school system will have the staff, resources, or training to conduct testing. Public health officials should work with schools to help link students and their families, teachers, and staff to other opportunities for testing in their communities.
Thank you, Dr. Massetti. We have one more question for you today. What if schools do not have the resources or funding to reopen using the CDC recommendation prevention measures?
Schools should adopt the recommended COVID-19 prevention strategies to the greatest extent they're able. A combination of approaches is essential. This guidance provides options for schools regardless of their resources or funding. Many of the recommended prevention strategies require minimal resources, and we have strong evidence that they reduce the spread of COVID-19. These include having everyone wear a mask correctly, maintaining at least 6 feet of distance between students, teachers, and staff, and ensuring everyone washes their hands and covers their noses and mouths with a tissue or inner elbow when coughing or sneezing. Additional information about each of the prevention strategies and options for implementing those strategies are provided in our new operational guidance. We also share information for how schools may consider each of these prevention strategies.
Thank you, Dr. Massetti. This concludes today's discussion and Q&A portion. Thank you to Dr. Massetti and Dr. McDonald, and thank you to everyone for joining our call today. A recording will be posted online on CDC's COVID-19 webpage and on YouTube in a few days. The subscription link to receive future updates and invitations is listed on the site. Enter your email and then search for COVID-19 Coronavirus Partners to subscribe. Our next call will take place Monday, March 1st, a week from today, when our topic will be progress around smoke-free policies during the COVID-19 pandemic. Until next time, Thank you for joining. Stay safe and be well.